What if the thing meant to save your life quietly changed who you are? 3 years ago, a 67-year-old woman walked into my operating room. She was sharp, active, completely independent. Her family had zero concerns. She came out of that surgery physically intact, but something was different. Her memory, her personality, her emotional responses, all subtly shifted. And nobody, not one member of her care team, had ever warned her family that this was even a possibility. I'm Dr. Sarah Kevin, a cardiothoracic surgeon with 10 years in the operating room, and today, I'm going to tell you something that most doctors never get around to saying out loud. If you are over 60, or if you love someone who is, this might be the most important video you watch all year. Because what I'm about to share doesn't make it onto pamphlets, it gets buried in consent forms nobody reads, and it gets skipped in pre-op appointments that move too fast. So let's slow it down right here. Here is the truth. Anesthesia does not work the same way in a 65-year-old body as it does in a 35-year-old body. Not remotely. And I'm not talking about worst-case dramatic outcomes. I'm talking about the quiet, slow-moving consequences that unfold over days and weeks after the surgeon has already moved on to the next case. By the time this video is over, you will know exactly what those consequences are, why they happen, and what you can do about them before you ever step foot in an operating room. Let's start with the biology, and I promise to keep this grounded. When anesthesia enters your system, it doesn't simply put you to sleep. It gets processed by your liver, filtered through your kidneys, and it crosses directly into your brain. In a younger patient, all three of those systems are running at full capacity. In someone in their mid-60s or beyond, the picture looks very different. By your mid-60s, your liver's ability to break down drugs has typically declined by 30 to 40%. That means anesthetic agents linger in your system far longer than they should. A dose that's perfectly calibrated for a 40-year-old can effectively become an overdose for someone older. Then there are the kidneys. Kidney function naturally decreases with age. And since many anesthetic drugs and their byproducts are cleared through the kidneys, slower clearance means longer exposure and a significantly higher risk of confusion and cognitive side effects after surgery. But here's the part that surprises people most. The aging brain actually becomes more sensitive to anesthetic agents. It requires less drug to reach the same depth of sedation, yet because it clears the drug so slowly, it ends up exposed to more of it for a longer period. Think of it this way. If anesthesia were a glass of wine, a 30-year-old metabolizes it in about 45 minutes. A 70-year-old is still feeling its full effects 4 hours later. Now scale that into a surgical setting with intravenous drugs, and you start to see the problem. Add in any pre-existing condition, hypertension, diabetes, atrial fibrillation, or even mild undiagnosed cognitive decline, and the risk equation shifts dramatically. There are 3 specific risks I want to walk you through, not the vague warnings on the consent form. The ones your anesthesiologist may mention briefly or skip entirely. The first is post-operative cognitive dysfunction, known as POCD. This is not a stroke, it's not dementia, but it can look disturbingly similar to both. POCD is a measurable decline in memory, concentration, and mental processing speed that occurs after surgery. Studies show it affects between 25 and 40% of adults over 60 who undergo major surgery under general anesthesia. For most, it resolves within weeks. But for patients over 70 or those with any early signs of cognitive decline, the effects can persist for a year or longer. Families notice it. They say their father or mother just hasn't been the same since the surgery. And they are usually right. The combination of surgical inflammation and the direct effects of certain anesthetic agents disrupts normal brain signaling in older patients in ways that simply do not happen in younger ones. The second risk is cardiovascular stress during anesthesia. General anesthesia causes a drop in blood pressure. In a young, healthy cardiovascular system, that drop is temporary and self-correcting. In an older patient with any degree of arterial stiffness or coronary disease, That same drop can trigger a cardiac event before the surgery has even properly begun. This is not a reason to refuse surgery when surgery is necessary. It is a reason to demand a thorough, comprehensive preoperative cardiac evaluation, not just a routine EKG. The third risk is post-operative delirium, and it is one of the most under-recognized complications in elderly surgical patients. It appears 24 to 72 hours after surgery as sudden confusion, disorientation, agitation, or unusual withdrawal. It affects up to 50% of older patients after major cardiac or orthopedic procedures, and it is routinely dismissed as just the anesthesia wearing off. But delirium is not harmless. Research connects it directly to longer hospital stays, higher complication rates, and an accelerated progression toward permanent cognitive decline in vulnerable patients. So here is your action plan. First, ask specifically about the anesthesia plan, not just the surgical procedure. Request to speak with your anesthesiologist before the day of surgery. Ask whether regional anesthesia, a spinal block, epidural, or nerve block, is a viable option for your case, because for many procedures it absolutely is, and it eliminates the systemic risks of general anesthesia entirely. Second, bring a complete medication list to every preoperative appointment. Every prescription, every supplement, every herbal remedy. Blood thinners, antidepressants, even melatonin can interact with anesthetic agents in ways that elevate your risk. Your team cannot protect you from interactions they don't know exist. Third, if you are over 65, request a baseline cognitive assessment before surgery. It is not an admission of weakness. It is a reference point that protects you and informs your care team about any pre-existing vulnerability that should shape the anesthesia protocol. Fourth, ask your care team directly, what is your monitoring protocol for post-operative delirium in older patients? Simply asking that question signals that you are informed, and research consistently shows that when delirium is being actively watched for, outcomes improve. Fifth, bring someone with you to every preoperative appointment, someone whose only job is to listen, ask questions, and remember what was said, because anxiety has a way of erasing everything the moment you step out of that office. Here at BioWell Hub, we believe that the most powerful thing you can bring into any medical situation is knowledge. The patients who recover best are not always the healthiest. They are the most prepared. Share this video with someone over 60 in your life. The window to act on this information is before surgery, not after. Drop your questions in the comments below. I read every single one, and if you want a printable pre-surgery checklist to bring to your next appointment, the link is in the description. Stay informed, stay empowered, and we'll see you in the next one.